These three common blood pressure pills are secretly aging you faster. After 60 brand new, shocking research from two of the largest blood pressure trials ever conducted has revealed a disturbing truth. Three of the most commonly prescribed blood pressure medications are quietly doing the opposite of what your doctor told you they would do. These three pills are sitting in medicine cabinets across America right now. Millions of seniors take them every morning. Inside the body of every senior who swallows one, a chain of damage is unfolding. It looks exactly like aging. It feels exactly like getting old. And it gets blamed on everything except the pill that is causing it. The tiredness that sleep cannot fix. The blood sugar that keeps creeping up even though you changed your diet. The swollen ankles your doctor calls fluid retention. The palpitations that come out of nowhere while you are sitting on the couch. The bedroom problems nobody wants to talk about. The skin that burns in 5 minutes of sun when it never burned before. Every one of these has been blamed on aging by millions of seniors whose doctors never connected the symptom to the pill. One of these pills was called the placebo with side effects at a cardiology conference. A study of 24,000 patients proved it reduces heart attack risk by exactly 0%. Zero. It does not save a single life. It only produces side effects. It is still prescribed to millions of seniors today. The system that wrote the prescription has not updated it in over 20 years. A second pill drains 2 minerals from your body that your heart needs to beat properly. When those minerals get low enough, your heart's electrical system starts misfiring. The same pill turns your skin into what one researcher called a solar-powered mutation. Factory. 700% increased risk of skin cancer after long-term use. The third pill forces your arteries open so aggressively that your brain thinks you are bleeding internally. Your kidneys panic and start retaining fluid. Over months and years, this panic response stretches your heart muscle until it fails. A pill prescribed to protect your heart ends up drowning it. These are not rare medications. These are the pills your doctor reaches for first. Cheap, familiar, on the treatment flow chart since before most seniors were diagnosed. There are 3 types of seniors watching this video right now. The first type takes their blood pressure pills every morning without questioning whether those specific pills are still the right ones. The second type is you. You have felt the fatigue and noticed the swelling. You have watched your blood sugar climb and wondered why your diet changes are not working. You suspect the pill might be the problem, but you do not know how to prove it, and you do not know what to say to your doctor. The third type asked for the blood tests, brought the study names to the appointment, had the conversation, and switched to a modern alternative that controls their blood pressure without destroying their heart, their metabolism, or their independence. This video is about how you become the third type. Imagine this. 3 months from now, you walk into your doctor's office with a list of blood tests you requested. The numbers tell a story your doctor has never seen from you before. Your fasting glucose dropped 15 points. Your potassium is stable. Your ankles are normal, and your energy is back. Your doctor looks at the chart and says, "Whatever changed, it's working." What changed is one pill removed, replaced with a modern alternative that does the same job, without the collateral damage. That is where this video takes you. And stick around, because what we uncover about the third pill is going to make you rethink everything you thought you knew about heart health. A story from a retired postal carrier, 73 years old. He walked 12 miles a day for 31 years, rain or shine, the most reliable man on his route. When he retired, he walked every morning out of habit, 3 miles before breakfast. Then his doctor put him on a blood pressure pill. Within a year, the morning walks stopped. He told his wife he just didn't feel like going out anymore. He sat in his recliner most of the day. His wife thought he was depressed. His daughter thought he was giving up. His doctor said he was managing fine because his blood pressure at the 1 hour appointment looked perfect. He was not depressed. He was not giving up. He was on a specific type of beta blocker, and that beta blocker had chemically removed the one thing that made him get out of the chair every morning. The first pill is a specific type of beta blocker, a small white or pink pill. If your blood pressure bottle says this drug, this section is about to change how you see every morning you have spent in that recliner. Cardiologists have a private name for this beta blocker. They call it the placebo with side effects. That name was born in 2004 when a study analyzed outcomes from over 24,000 patients across every major trial of this drug. They weren't looking at blood pressure numbers on a cuff. They were looking at who lived and who did not. When this beta blocker was compared head-to-head with a sugar pill, it reduced cardiovascular mortality by exactly 0%. It did not prevent heart attacks. It did not extend life by a single day. The only things it reliably produced were chronic fatigue, blunted heart rates, rising blood sugar, and bedroom problems nobody discussed at the appointment. Why does this drug fail while lowering the number on the cuff? Because the number on your cuff is not the number that matters. Your cuff measures the pressure in your arm, but the pressure that determines whether you have a stroke is inside the aorta, the main pipe leaving your heart that feeds your brain. A study measured both pressures in the same patients. The arm pressure was nearly identical between this beta blocker group and the comparison group, but the central aortic pressure, the pressure inside the pipe feeding your brain, was higher in the beta blocker group. This is why when your heart pumps, it sends a pressure wave down the aorta like a shock wave through a tunnel. That wave travels down to where the arteries branch at your legs, bounces off the branch point, and returns back up toward the heart. In a healthy system, this reflected wave arrives back at the heart after the heart has finished pumping during the resting phase. It arrives at the perfect time to push blood into the coronary arteries that feed the heart muscle itself. This beta blocker slows the heart so dramatically that the timing changes. The heart takes longer to pump. The reflected wave bounces back too early. Instead of arriving during the resting phase, it crashes into the aorta while the heart is still actively trying to push blood out. Two forces colliding head-on inside the main pipe. Your arm cuff cannot detect this collision. Your doctor sees a 128/82 on the cuff and says, "Perfect." Inside your chest, the aorta and the delicate vessels feeding your brain are absorbing the impact of a head-on pressure collision with every single heartbeat. A major trial in 2002 proved the consequences. Over 9,000 seniors were randomized to this beta blocker or another drug. Despite nearly identical arm pressure readings, the alternative reduced strokes by 25% compared to this beta blocker and reduced new-onset diabetes by 25%. Same arm numbers, dramatically different outcomes because the arm number was never the number that mattered. Leave a comment right now. Tell me if you are on this type of beta blocker and how long. Because every comment pushes this video to one more senior whose doctor has not revisited that prescription since the day it was written. This beta blocker was doing more than killing that man's motivation. It was quietly building a second disease inside his body. It blocks the beta-2 receptors on the surface of the pancreatic cells that produce insulin. When those receptors are blocked, the calcium channels inside the cell cannot open. Without calcium, the tiny packets of insulin that the cell manufactured cannot fuse with the cell wall to be released into the blood. The insulin is made. It is sitting inside the cell in tiny packets, but the delivery mechanism is frozen. Meanwhile, glucose is piling up in his blood because the insulin is locked inside the factory. His fasting glucose climbed from 95 to 118 over 2 years. His doctor saw 118 and said, "You are pre-diabetic. Watch your carbs." He cut out bread, pasta, and sweets. His glucose stayed at 116, so he cut out fruit. Still 114. He was starving himself of foods he loved, and the number barely moved because the problem was never his diet. The problem was a pill freezing the insulin delivery system inside his pancreatic cells. A major study confirmed a 28% increased risk of new-onset diabetes in seniors on this beta blocker. Not from eating too much sugar, from a blood pressure pill, paralyzing the cells that release insulin. If you are on this beta blocker and your blood sugar has been creeping up while your diet has been getting stricter, your pancreas is not failing. It is being held hostage. The insulin is there. The delivery system is frozen. How many months have you been blaming yourself for a blood sugar number your pill created? But this beta blocker does one more thing that nobody discusses at the appointment. It blocks the beta receptors, but leaves the alpha-1 receptors completely unopposed. Alpha-1 receptors are the body's vascular gatekeepers. Their job is to constrict blood vessels. When this beta blocker removes the counterbalance, the alpha-1 receptors clamp down on blood vessels throughout the body, including the vessels that supply blood flow to the pelvic region. A study documented a 12.6% incidence of sexual dysfunction in men on this beta blocker. The brain sends the arousal signal. The nerves release nitric oxide, but the alpha-1 receptors have padlocked the arteries shut. The signal fires, but the gates will not open, and this beta blocker caps your heart rate during exercise at approximately 110 to 120 beats per minute, regardless of how hard your body is working. A healthy senior's heart should reach 140 to 150 during a brisk walk. This beta blocker prevents that response. Your muscles scream for oxygen. Your heart is not allowed to deliver it. That is why exercise feels impossible. You are not out of shape. Your heart is being held back by a chemical leash. That man thought he was aging out of his walks. He was being chemically restrained from taking them. Think about what this means for your daily life. Every time you tried to walk up the stairs and felt winded, you blamed your age. Every time you sat down after one block, you assumed your heart was weak. Every time your spouse walked ahead and you could not keep up, you felt ashamed. You were not weak. Your heart was being held on a chemical leash that prevented it from delivering oxygen to your muscles. The shame is the cruelest part. The fatigue makes you stop exercising. When you stop exercising, your muscles weaken, your balance deteriorates, your bones thin, and your fall risk increases. The pill that was supposed to protect your heart created a sedentary spiral that attacks your heart from the other direction. Inactivity is one of the top 5 risk factors for cardiovascular disease. This beta blocker forces inactivity by making exercise feel impossible. The pill creates the very risk factor it was prescribed to prevent. 26% of seniors on this beta blocker report fatigue severe enough to limit daily activity, 1 in 4. A study confirmed that this fatigue is not from lower blood pressure. It is from reduced cardiac output and skeletal muscle starvation caused by this beta blocker. Specifically, newer beta blockers like one that releases nitric oxide do not cause this because they maintain blood flow to muscles. The fatigue is not a necessary price of controlling blood pressure. It is a defect of an outdated drug. How many mornings have you chosen the recliner over the walk because your body told you it could not handle it? Your body was not failing. Your pill was holding it back. This beta blocker was approved in 1981. A major trial proved it inferior in 2002. It took until 2014 for some guidelines to downgrade it. During those 12 years, tens of millions of new prescriptions were written for a drug the science had already proven was the wrong choice. That man's prescription was written in 2018, 16 years after the evidence changed. Subscribe right now because the next video covers the one mineral that reverses the damage this beta blocker does to the pancreas. If you are not subscribed, you will not see it. The second pill is a common diuretic, a water pill. It has been prescribed since 1959, and it is still one of the most commonly used blood pressure medications on Earth. Your doctor chose it because it is cheap, it is familiar, and it lowers the number on the cuff reliably. What your doctor did not explain is what it drains from your body along with the water. This diuretic works inside the kidney at a specific location. It blocks a channel that reabsorbs sodium. The sodium stays in the urine, and water follows it out. Blood volume drops, and blood pressure drops. Simple. But the sodium that this diuretic forces downstream does not leave your body quietly. It floods into the collecting duct. The collecting duct sees this massive wave of sodium and panics. It activates a hormone that forces the duct to reabsorb the sodium by exchanging it for potassium. Your kidneys dump potassium into your urine to save the sodium. Day after day, month after month, your potassium level drops from a healthy 4.2 down to 3.4. At 3.4, your doctor says, borderline low. Maybe eat a banana. What 3.4 actually means is that the electrical reset system in your heart is already dragging. Every heartbeat has a precise electrical sequence. Sodium channels fire to contract the heart muscle. Then potassium channels open to reset the charge so the heart can beat again. When potassium is low, the reset drags in slow motion. On an EKG, this appears as a stretched QT interval. The heart is caught in an electrical twilight, neither fully contracted nor fully relaxed. And in that vulnerable window, a rogue electrical impulse from another part of the heart can ignite a chaotic rhythm called torsades de pointes. The heart quivers instead of pumping. Blood stops reaching the brain. You hit the floor. Your doctor called it borderline. An electrophysiologist would call it a ticking clock. You are 0.3 away from the threshold where the window for a fatal arrhythmia rips open. At 25 milligrams of this diuretic, 10 to 20% of seniors develop hypokalemia. At 50 milligrams, up to 40%. And this diuretic does not only drain potassium, it strips magnesium from your blood through the same mechanism. When intracellular magnesium drops, the smooth muscle cells inside your artery walls undergo a terrifying transformation. Starved of magnesium, these cells activate a genetic switch. This switch is not a vascular gene. It is the master switch for bone formation. The smooth muscle cells forget they are supposed to be flexible artery tissue and begin transforming into bone-building cells. They start secreting calcium and phosphate directly into the artery wall. Your blood vessel is literally turning into bone from the inside out. No blood pressure pill can reverse this because no chemical can uncalcify bone inside a living artery. And here's the part that will make you check your skin tonight. This diuretic molecule contains a ring that acts as a photosensitizer. It embeds in your skin cells and becomes violently reactive to ultraviolet light. When you walk outside, the UV photons from the sun strike the molecules sitting in your skin. The molecules absorb the energy and shed electrons, generating swarms of free radicals that tear through the DNA inside your skin cells. In a healthy person, DNA repair enzymes fix occasional sun damage, but the relentless daily drug-amplified damage overwhelms the repair system. The mutations pile up. The cells forget how to stop dividing. A study found a 700% increased risk of squamous cell carcinoma after a cumulative dose of 50,000 mg. That's roughly 11 years of continuous use at 12.5 mg per day. If you have been on this diuretic for a decade, check your skin tonight. New lesions, spots that do not heal, areas that crust and bleed. Your pill may be the reason. Leave a comment. Tell me how many years you have been on this diuretic. Because 700% is not a number any senior should learn about from a YouTube video. It's a number their doctor should have told them the day the prescription was written. I read every comment on these videos. The question I see most is how to talk to me directly about your specific pill combination. A video talks to everyone, but it cannot look at your bottles. Every day I write one email. When you write back, I write back. You can sign up for free, the first link below this video. The third pill is a very common calcium channel blocker, often known by its brand name. This is one of the most prescribed blood pressure medications in the world. It's a calcium channel blocker that relaxes your artery walls by blocking the calcium channels in smooth muscle cells. Your arteries open, blood flows more easily, and pressure drops. That is the version that fits in a 5-minute appointment. That version leaves out the most important part. This calcium channel blocker blocks L-type calcium channels, specifically in the precapillary arterioles, the tiny arteries that feed into your capillary beds. These arterioles open wide under the drug's influence. But the postcapillary venules, the tiny veins that drain the capillary beds, do not have L-type calcium channels. The drug cannot relax them. They stay narrow. Now you have a fire hose volume of blood slamming into a capillary bed that can only drain through a narrow exit. The pressure inside the capillary skyrockets. Capillary walls are semi-permeable by design, meant to let tiny nutrients seep through. But under this drug-induced hydrostatic pressure, clear plasma fluid is squeezed through the capillary walls and dumped into the tissue of your ankles and feet. It pools there, stretching the skin until it is tight and shiny. This is not fluid retention from eating salt. This is a mechanical blowout of the microvascular plumbing. At 5 milligrams, 3 to 11% of patients develop this edema. At 10 milligrams, up to 30%. And in women, the rate is even higher. Here's the prescribing cascade that makes this worse. Your doctor sees swollen ankles and prescribes a diuretic to remove the fluid. The diuretic depletes potassium and magnesium. Now you are on 2 pills. The second one treating a side effect of the first while creating its own side effects. The diuretic does not fix the pressure mismatch. It just drains fluid that the calcium channel blocker keeps pushing out. The swelling comes back. The doctor increases the diuretic and the potassium drops lower. A pill to treat the side effect of a pill becomes a disease created by the treatment of a side effect. But the most dangerous thing this calcium channel blocker does happens deep inside your cardiovascular control system. When this drug forces your arteries open, your blood pressure drops suddenly. The baroreceptors in your neck detect this drop and interpret it as a medical emergency. Your brain fires the sympathetic nervous system, convinced you are losing blood. The kidneys receive a panic signal and activate the renin-angiotensin-aldosterone system. They lock down sodium and water to expand blood volume. Your heart is now forced to pump this artificially expanded ocean of fluid every minute of every day. Over months and years, the continuous strain stretches the left ventricle like an overused rubber band. The thick muscular wall thins. The pumping power drops. A major trial found a 38% higher risk of heart failure with this calcium channel blocker compared to an alternative. A pill prescribed to protect the heart ends up drowning it in volume it was never designed to handle. How many months have your ankles been swollen? How many times has your doctor added a pill to treat a side effect instead of removing the pill that caused it? Now, here's the part I haven't told you yet. And this is where the three pills stop being individual problems and become one connected disaster. Many seniors are on all three at the same time: this diuretic, that beta blocker, and this calcium channel blocker. When these three drugs operate simultaneously inside your body, the drugs do not cooperate. The drugs fight each other. But before I show you how they fight, you need to understand why these pills hit you harder at 75 than they did at 55. Because the dose on your bottle was calculated for a younger body with faster organs. Nobody adjusted it as those organs slowed down. That beta blocker is cleared almost entirely by your kidneys. It is water-soluble. At 45, your kidneys filter blood at full speed with an eGFR above 90. The beta blocker enters your blood, does its job, and your kidneys flush it out before the next dose arrives. At 75, the natural aging process drops your eGFR to 60 or even 45. Your kidneys filter at half speed. When you take your daily dose, the kidneys cannot clear it in time. The next morning, you swallow another dose, while a significant amount of yesterday's is still circulating. Dose stacks on dose. A standard dose pill behaves like an overdose. Your heart rate drops into the dangerous 40s. Your fatigue doubles and your exercise tolerance drops to near zero. Your doctor sees the slow heart rate and thinks the drug is working because a slow rate is what beta blockers produce. The difference between a therapeutic heart rate of 60 and a dangerous rate of 42 comes down to one organ: a kidney filtering at 90 versus one filtering at 50. Same pill, same dose, different body. This calcium channel blocker faces the opposite trap. It is metabolized by your liver through an enzyme pathway. By age 70, blood flow to the liver drops 30 to 40%, and the liver physically shrinks. The enzymes become sluggish. This calcium channel blocker already has a half-life of 30 to 50 hours in a younger person. In a senior with slowed liver function, that half-life extends dramatically. The drug accumulates because the liver cannot break it down fast enough. The arterial floodgates in your legs are wedged open permanently. The ankle swelling risk jumps from 10% to over 30% purely because of your age. This diuretic hits differently too. As kidney function declines, this diuretic becomes less effective at lowering blood pressure because it depends on kidney filtration to work. But it remains fully effective at draining potassium and magnesium. The blood pressure benefit fades. The mineral depletion continues at full force. You get all the side effects and less of the benefit. If you are over 70 and on the same doses you were given at 60, your medications are almost certainly hitting you harder than intended. Your kidneys clear the beta blocker slower. Your liver clears the calcium channel blocker slower. Your diuretic drains minerals while delivering less blood. Pressure control. How long have you been on the same dose without anyone checking whether your kidneys and liver can still handle it? Now, back to what happens when all three are working at the same time inside your body. The calcium channel blocker forces arteries open, which triggers the kidneys to retain sodium and water through the renin-angiotensin system panic response. But the diuretic is sitting right next to those same kidney pathways trying to force sodium and water out. Your kidneys are simultaneously being whipped to retain fluid by the calcium channel blocker cascade and poisoned to dump fluid by the diuretic. This pharmacological tug-of-war ravages the delicate filtering units in your kidneys. Meanwhile, the diuretic is draining the potassium your heart needs to reset its electrical system after every beat. If the heart begins to misfire from low potassium, the sympathetic nervous system would normally fire a massive dose of adrenaline to stabilize the rhythm. But the beta blocker has padlocked the beta-1 receptors. The rescue signal bounces right off the heart. The diuretic pushes you toward a cliff. The beta blocker cuts the parachute, and the metabolic damage multiplies. The diuretic starves the pancreas of potassium needed to trigger insulin release. The beta blocker simultaneously blocks the beta-2 receptor that completes the release. The pancreatic cell is under a double chemical siege. It cannot get the potassium signal to start the release, and it cannot use the receptor to finish it. The risk of new-onset diabetes does not add up. It multiplies. That retired postal carrier was on all three. His fasting glucose was 118. His potassium was 3.4. His ankles were swollen. And his heart rate was stuck at 52. He could not walk to the mailbox without stopping. His doctor saw 128/82 at the 1-to-odds appointment and said, Everything looks great. Everything was not great. 3 pills were fighting a war inside his body, and his doctor was reading the score from the wrong scoreboard. This is what happened when 1 pill was removed. His daughter, a nurse practitioner, looked at his pill bottles and said, "Dad, why are you on that beta blocker? A major trial proved a better alternative is better 20 years ago." He said, "Because my doctor prescribed it." She said, "The evidence changed. Your prescription did not." She called his doctor the following Monday. They agreed to taper the beta blocker over 4 weeks and replace it with the alternative. Week 1, the chemical padlocks fell off the beta-1 receptors. His heart rate rose from 52 to 67. Oxygenated blood reached his muscles for the first time in 2 years. The crushing leg fatigue that made the recliner feel like the only option began to lift. He stayed awake past 8 hours for the first time in months. Week 2, the beta-2 receptors on his pancreatic cells were finally unblocked. The tiny motors inside the cells that push insulin out of the membrane woke up. The massive backlog of trapped insulin was released into his bloodstream. Month 1, his fasting glucose dropped from 118 to 96. The prediabetes diagnosis vanished, not because he changed his diet. He had already tried that for 2 years. The chemical hostage situation inside his pancreas was over. The insulin was finally free to do its job. Month 3, the alpha-1 vasoconstriction in his pelvis resolved. The autonomic balance returned. He did not mention this to his daughter, but his wife noticed. She did not say anything directly. She just smiled one morning in a way she had not smiled in a long time, and the walks came back. 3 miles before breakfast, rain or shine. The postal carrier in him never left. The pill had buried him. The removal set him free. His daughter said, "One thing that I want you to hear." She said, "Dad was not getting old. Dad was getting medicated, and the medication was aging him faster than time ever could." If you are on any of these 3 pills, here are the blood tests that reveal the damage. For the diuretic, ask for serum potassium and an RBC magnesium test. Serum magnesium can look normal while your cells are depleted. The RBC test measures what is actually inside the cell. If your potassium is below 3.5, you are in the danger zone. If your RBC magnesium is low, your arteries may already be calcifying. For the beta blocker, ask for fasting glucose and fasting insulin. If your glucose is high but your insulin is low, that proves the pancreas is not resistant, it is paralyzed. A true diabetic has high insulin because the body pumps out more to overcome resistance. Low insulin with high glucose means the pill is trapping insulin inside the cell. That one test can erase a diabetes diagnosis. For the calcium channel blocker, ask for plasma renin activity and serum aldosterone. If both are elevated, your kidneys are in a state of biological terror. They think you are hemorrhaging. The heart failure cascade is active. Your left ventricle is being stretched every single day. Ask yourself right now, when was the last time your doctor checked your potassium? Not your blood pressure, your potassium. If you are on that diuretic and nobody has checked it in 6 months, your heart's electrical system may already be dragging and nobody is monitoring it. When was the last time anyone checked your fasting insulin alongside your fasting glucose? If you are on that beta blocker and your glucose is above 110, one blood draw can prove the truth. It shows whether you are developing diabetes or whether your pill is trapping insulin inside the factory. That test costs less than the medication your doctor might write without running it. When was the last time anyone measured your RBC magnesium? The standard serum magnesium test can look normal, while the magnesium inside your cells is critically depleted. The RBC test measures what is actually inside the cell. If you are on that diuretic and your serum magnesium looks fine, your doctor will say you are good, but your artery walls may already be calcifying because the intracellular magnesium is gone. These 3 tests together tell a story no blood pressure reading can tell. Your potassium reveals whether your heart's electrical reset is safe. Your fasting insulin reveals whether your pancreas is paralyzed or resistant. Your RBC magnesium reveals whether your arteries are turning to bone. These tests cost less than dinner at a restaurant. Most are covered by Medicare, and they tell a story your doctor has never read because nobody ordered the right chapter. Here are the exact words to say to your doctor. For the beta blocker, say this: "Doctor, that major trial tracked 9,000 patients and showed a better alternative reduces strokes 25% more than this beta blocker with 25% less diabetes. I would like to discuss a supervised taper to transition to that alternative." For the diuretic, say this: Doctor, a study linked this diuretic to a 700% increase in squamous cell carcinoma from its photosensitizing mechanism. I would like to switch to a metabolically neutral or a potassium-sparing alternative. For the calcium channel blocker, say this: Doctor, that major trial found this drug carries a 38% higher heart failure risk because it triggers a specific kidney response. My ankles are swelling, and I do not want a diuretic added to treat a side effect. I would like to replace this drug with an alternative that provides the same protection without the microvascular pressure mismatch. If your doctor says you have been stable and does not want to change, say this: I understand. You know my history best, but I am experiencing fatigue and my blood sugar has been climbing. I want to see if those improve on a different medication. Can we try a supervised switch? The word stable is doing heavy lifting. Stable means the number on the chart has not gotten worse. Stable does not mean you feel good. Stable does not mean your potassium is safe. Stable does not mean your arteries are not calcifying. Stable means the chart looks the same as last time. That is enough for a 15-minute appointment. It is not enough for your life. If your doctor still will not engage, ask for a referral to a specialist. A specialist does this every day. The specialist knows the taper protocols, the modern alternatives, and the specific interactions between your pills. Data changes conversations. Opinions start arguments. Bring the study names and the blood test results. The numbers do the talking. Do not stop any of these pills on your own. That beta blocker especially must be tapered. If you have been on a beta blocker for years, your heart grew extra adrenaline receptors to fight the drug. Stopping suddenly exposes all those receptors to a flood of adrenaline at once. Your heart rate can spike to 140. Your blood pressure can surge. You can trigger a heart attack within 48 hours. This must be supervised. Your doctor cuts the dose in half, waits 2 weeks, halves it again, then stops while starting the replacement. About a month of careful transition. There is one more detail about age that changes everything about these pills. Your body at 75 is a different machine than your body at 45. That beta blocker is cleared almost entirely by the kidneys. At 45, your kidneys filter blood at full speed. At 75, the natural aging process drops that filtering speed. When you take your daily dose, the kidneys cannot clear it in time. The next morning, you take another dose while a significant amount of yesterday's is still circulating. Dose stacks on dose. A standard dose pill behaves like an overdose. Your heart rate drops into the dangerous 40s. That calcium channel blocker faces the opposite trap. It is metabolized by the liver. By age 70, blood flow to the liver decreases by 30 to 40%, and the liver physically shrinks. The enzymes become sluggish. This calcium channel blocker already has a half-life of 30 to 50 hours in a young person. In a senior with slowed liver function, that half-life extends dramatically. The drug accumulates. The arterial floodgates in your legs are wedged open permanently because your liver cannot break down the drug fast enough. The ankle swelling risk jumps from 10% to over 30% purely because of age. These pills were tested on younger, healthier bodies. Your body is older and slower now, and nobody adjusts the dose as the body changes. That beta blocker was approved in 1981, making it 45 years old. The diuretic was approved in 1959, making it 67 years old. The calcium channel blocker was approved in 1992, making it 34 years old. The average time between a landmark study proving a drug is inferior and the medical guidelines being updated to reflect it is 17 years. The trial, proving that beta blocker inferior, was in 2002. The guidelines did not fully downgrade it until 2014 in some countries and 2019 in others. During that gap, tens of millions of new prescriptions were written for an inferior drug, while superior alternatives sat on the same pharmacy shelves. Hundreds of thousands of strokes worldwide that statistically would have been prevented if the prescription pads had simply matched the science. Your prescription does not have an expiration date. It renews automatically year after year. The science moves forward. The prescription stays frozen. And every year it stays unchanged, the pill that was supposed to protect your heart is quietly doing the opposite. In Australia, Canada, and the Netherlands, doctors practice systematic deprescribing. Once a year, the doctor sits down with every senior patient and goes through every bottle on the counter asking one question: is this still the right drug for this person at this age with these kidneys? A study showed that systematic deprescribing reduced one-year mortality by 88%, not 8%. 88%. In America, most doctors do not deprescribe. They refill. The average senior over 75 takes 5 to 9 pills a day. Studies show that when specialists review these lists and remove the unnecessary ones, patients feel better. Fewer falls, fewer hospitalizations, and fewer side effects that had been blamed on getting old. There is a movement in medicine called deprescribing. It is the planned, supervised removal of medications that are no longer helping or are actively hurting. In Australia, Canada, and the Netherlands, this is becoming standard for seniors over 75. Once a year, the doctor sits down with every senior patient and reviews every bottle on the counter. One question: is this still the right drug for this person at this age with these kidneys and this liver? A study measured what happens when specialists systematically deprescribe in older adults. The results were staggering: an 88% reduction in one-year mortality. Removing the wrong pills turned out to be more powerful than adding the right ones. Fewer falls, fewer hospitalizations, fewer side effects that had been blamed on aging. Seniors got back pieces of their life they thought were gone forever. The average senior over 75 in America takes 5 to 9 pills a day. Approximately 15 to 20% of seniors with high blood pressure are on 3 or more blood pressure medications simultaneously. Each additional pill increases the risk of interactions, side effects, falls, and hospitalizations. But the system is built to add pills, not subtract them. Your prescription renews automatically. Nobody goes back to check whether the pill that made sense at 60 still makes sense at 75 with kidneys running at half speed. That beta blocker was approved in 1981, the diuretic in 1959, and the calcium channel blocker in 1992. The average time between a landmark study proving a drug is inferior and the medical guidelines updating to reflect it is 17 years. The trial proved that beta blocker inferior in 2002. Some guidelines did not fully downgrade it until 2019. During that 17-year gap, tens of millions of prescriptions were written for a drug the science had already rejected. Hundreds of thousands of strokes that statistically would have been prevented if the prescription pads had matched the evidence. The true cost of this gap is not measured in years. It is measured in paralyzed limbs, lost speech, and families who trusted a system that was 2 decades behind the truth. And the reason these specific pills remain on so many counters is not because they are the best options. They are the cheapest options. Insurance formularies and pharmacy benefit managers prioritize immediate cost over long-term outcomes. A month of that beta blocker costs $2. A month of the alternative costs $8. The system saves $6 per month while the patient endures fatigue, rising blood sugar, and a 25% higher stroke risk. The $6 savings costs the healthcare system tens of thousands of dollars when the stroke arrives. But the stroke is a different budget line, and in American medicine, nobody connects the two. You do not have to wait for the American medical system to catch up. You can walk into your office with the study names, the blood test requests, and the conversation scripts from this video. You can be the one who asks the question the system forgot to ask. Is this still the right pill for me? That retired postal carrier went from 3 blood pressure pills to 1. His blood pressure is controlled. His fasting glucose is 96. His potassium is 4.1. His ankles are normal, and his heart rate is 67. He walks 3 miles every morning before breakfast. His wife stopped watching from the window. She stopped wondering if today is the day he does not come back. His daughter said the thing that should haunt every senior on an outdated prescription. The system does not go back and check. The prescription renews automatically. The science changes. Your pill does not unless someone walks in and asks the question. The question is simple: is this still the right pill for me? The answer might be yes. Some seniors need their beta blocker, some need their diuretic, and some need their calcium channel blocker. But the answer cannot be yes unless someone asks the question. And if nobody has asked in the last year, you need to walk in and ask it yourself. The blood pressure protocol is my ebook. The full system. Not one pill, not one number. The protocol looks at everything together. The blood pressure, the blood sugar, the potassium, the magnesium, the kidney markers, the artery stiffness, the overnight readings. It treats your body as one connected system because that is what it is. You follow it. Your doctor sees numbers improving across the board. Instead of one number dropping while 3 others quietly climb, the entire picture changes. The pill conversation changes. The dosage changes. The number of bottles on your counter starts going down instead of up. You will not find this in a bookstore, not on Google, not on Amazon. This is knowledge from holding these organs in my hands and seeing what these drugs do from the inside. Every day on the wrong pill is another day your pancreas is paralyzed, another day your arteries calcify, another day your heart muscle stretches. The protocol is how you start asking the right questions. The questions your doctor should have asked years ago. Senior Health Life Daily free, first link below this video. Reply to the welcome email and tell me which pills are on your counter right now. I read every reply personally. The person watching after you will read the comments first. That person is looking for someone who takes one of these pills, someone who feels the tiredness, someone who has the swelling, someone whose blood sugar keeps climbing while their diet keeps shrinking. Your comment is for that person. Tell me 3 things: which blood pressure pills you take, how long you have been on them, and whether anyone has checked your potassium in the last year. Those 3 answers might save the next person's heart rhythm, their pancreas, or their skin. Hit the like button. One tap puts this in front of a senior who is on one of these pills right now. A senior who has no idea what it is doing inside their body. Subscribe. The next video connects directly to what you learned today. Send this to one person tonight, the one who takes a handful of pills every morning, the one who is tired all the time and blames it on getting old, the one whose doctor says everything looks great while that person sits in the recliner wondering where their life went. That person deserves to know that perfect on the chart does not mean perfect in the body, and the pill that was supposed to help might be the pill that needs to change. That man got his walks back. His wife stopped watching from the window. His daughter stopped whispering. Not because he got younger, because he got the right pill. Your doctor has 5 minutes and a prescription pad written decades ago. This video just gave you 60 minutes and the science from today. The question is what you do with it tomorrow morning.